After going through the red flag signs of pediatric cancer deeply, I need to stress on some frequent presentations of pediatric cancer, namely one, anemia. When to suggest that this kind of anemia is of malignancy origin, when it's rapidly progressive, that requires repeated packed or whole blood transfusion. Anemia when associated with any of the following: bleeding, hepatosplenomegaly, lymphadenopathy, bone pains, or any masses in the body. Bone pain or joint pain. When pain is widespread or involves the back, which is very uncommon in children, or when it occurs at the same place every time, or when the child needs to have a painkiller to relieve it, or pain that's preventing the child from doing his routine, like playing, doing something. At this time, you have to think of a local malignancy. Lymph nodes. Enlargement of the lymph node is very common, especially in under 4, which is a sign of a lymphoid pattern of growth with enlargement of the lymph nodes in reaction to any infection or inflammation. So it's very common to have non-specific lymphadenopathy. But when to consider enlargement of the lymph node serious and needs more investigation, when the consistency is firm or hard, when it's not tender, when it's large, more than 3 cm across its largest diameter, when it's getting bigger rapidly, or when associated with other signs like fever or weight loss, when it's present in special places where it's not non-specific, like in the epitrochlear or the armpit, or in the collarbone, the supraclavicular group of lymph nodes. Sometimes enlargement of the lymph nodes can only be apparent by radioimaging. So mediastinal lymph nodes can be seen on plain X-ray of the chest, and abdominal lymph nodes can be visualized by pelvic-abdominal ultrasonography. Generally speaking, any swelling, any lump needs referral if it's rapidly growing, it's more than 3 cm in its largest diameter, if it's fixed to surrounding, doesn't move when examined, or it's deep-seated in the tissue, or the nearby lymph nodes are enlarged, meaning the catchment area of this lump where lymph nodes are enlarged, denoting spread or something wrong. Presence of any signs of puberty before the age of 8 in girls or 9 in boys warrants immediate referral and investigation for detection of the etiology of precocious puberty or premature puberty. The fourth intended learning outcome is about choosing when and what to choose and how to interpret results of the initial workup. Fever, which lasts more than 14 days with no localization, no etiology can be found explaining fever in the patient, then you have to ask for a complete blood count CBC with differential count and a blood film. Vomiting lasting more than 7 days, again with no identifiable cause, ask for an abdominal CT. If associated with headache, a CT brain or MRI brain is mandatory. Constipation, if prolonged more than 1 month and doesn't respond to conventional methods with diet regulation and cathartics, at that time an pelvic abdominal CT is recommended. Cough persistent more than 2 weeks, again with no etiology and not responding to all kinds of treatment, then a chest radiograph is essential. Bone or muscle pain that's prolonged more than 2 weeks, again plain X-ray to start with. This is followed by a complete blood count and the CT scan according to the result of the plain X-ray. Headache that occurs during sleep, especially if associated with neurological signs or vomiting or deterioration of school activity, In absence of family history of migraine, this necessitates an urgent CT or MRI brain. Hematuria, after being fully evaluated and no cause is found, pelvic abdominal sonography is important. Voiding difficulty, after being evaluated and no identifiable cause is found, then again pelvic abdominal sonography is mandatory. Lymphadenopathy that's persistent or rapidly increasing, as previously discussed, or is not responding to a 7-day course of broad-spectrum antibiotic, you have to request for a CBC with differential and one of the non-specific tumor markers, which is the lactate dehydrogenase level. Some examples of pediatric cancer found on the left side on routine chest X-ray with mediastinal lymphadenopathy, but further studying this patient, you'll find extensive anterior mediastinal lymph nodes. CT scan of the abdomen on the left side showing a huge mass. On the right side, you can visualize the right kidney. On the left side, the kidney cannot visualized at the same level due to compression or by the suprarenal tumor, which is a huge neuroblastoma tumor occupying the left side and crossing the midline, incarcerating the aorta with the black arrow pointing to the blood vessel. On the right side, a mass is very apparent by axial T1 weighted magnetic resonance image. As you see, it arises from the ventricular wall, and this could easily diagnose an epidymoma of the brain. Basic or essential labs that should be requested in any patient suspected of having cancer are the complete blood count, the chemical profile, that's the liver function, renal function tests, electrolytes, sodium, potassium, magnesium, calcium, and phosphorus, complete urine analysis, and according to the presentation, you may ask for bone marrow aspirate or biopsy, lumbar puncture as indicated also, or incisional or excisional biopsy of a mass. Sometimes tumor markers would be of help to identify the type of the tumor, like lactate dehydrogenase, which is very high in non-Hodgkin, Hodgkin disease and leukemia, as well as neuroblastoma. Neuron-specific enolase, it's also not a specific one, but it's found in tumors of neurological origin, especially neuroblastoma. Alpha-fetoprotein and human chorionic gonadotrophins are very important for liver tumors, and alpha-fetoprotein also for germ cell tumors. But cancer is diagnosed by visualization of cancer cell. So biopsy is recommended to get a sample and examine under the microscope for identification of tumor. As leukemia is the most common neoplasm, then a bone marrow should be requested when significant depression of one or more cell lines or abnormal blood counts are there in absence of infection inflammation to explain, when abnormal counts are associated with lymphadenopathy or hepatosplenomegaly, or when the blood film shows atypical or blast cells in the peripheral blood smears. Both bone marrow aspirate and the trephine biopsy are recommended. Fine needle aspiration cytology is indicated for any mass or enlarged lymph nodes. It's even useful and safe for deeply seated masses or mediastinal even nodes, but should be guided by ultrasonography or CT scan. However, if it's not conclusive, then a biopsy is a must. Sometimes incisional or excisional biopsy is recommended when a mass is localized to an organ, for example, the adrenal gland or the kidney, with no evidence of metastatic spread. Then excisional biopsy that's removal of the whole organ with the tumor involving the organ, or sometimes incisional biopsy, removing or getting part of the tumor for further studies. And this is recommended when the fine needle aspiration cytology is inconclusive. Do and don'ts in dealing with a child with suspected cancer. Please don't give steroids in suspected case of juvenile chronic arthritis unless a bone marrow aspirate is done first to exclude malignancy. Don't start antituberculous treatment in patients with lymphadenopathy without a definite diagnosis of tuberculosis. Please go for a lymph node biopsy if fine needle aspiration cytology is inconclusive and the cancer is highly suspected. And if a patient presents with severe anemia, but you suspect to have neoplasm, don't hurry for a definite diagnosis. Please give blood transfusion first to correct anemia, especially if there are impending signs of congestive heart failure, before a definite diagnosis is sought. By the end of this, I have achieved the 5th intended learning outcome. Now you know and you appreciate well how important to refer children suspected to have neoplastic disease as early as possible. Please be ready with your questions in the next face-to-face session. Thank you.